Great. Hello, everybody. Dr. Frank Losello. Again, I appreciate everybody attending these programs, especially the second one. So thank you very, very much for registering, and hopefully we could share some interesting information. So very, very briefly, as an introduction, I know I've introduced before, but those who may not have attended, a board certified prosthodontist. I was a program director forever, it seemed, associate clinical professor at University of Buffalo in New York, and director of removable prosthodontists here at Divaclar Vivadet. Um, I am basically mostly retired from most of all these things, but I have a passion for removable digital and have had the good fortune to be able to be part of the research development and now education of this particular process. So I consider myself quite fortunate. Okay. Sorry, let me just get this thing. Okay. The first part we focused on several of these points here in yellow, and we discussed the various technical advantages, which there are many. And technically, we can indeed, with this new technology, make a more accurate, a stronger denture with uniformity and consistent physical properties, and we discussed the monolithic aspect as well, with as a possibility now. So all these things are great technical advantages that we could take advantage of with this new technology, as well as clinically. There's many things we could gain as a clinician and patient, as far as the denture we deliver to the patient being more acceptable to them, more retentive, more feels better in their mouth, and all these things clinically we could accomplish with a collaboration elimination of a post-am, and most of all, or certainly very important feature being that we could electronically save this information, and at any given time we could recall it precisely with accuracy and remake the denture, or use it as a guide for the fabrication of a new prosthesis. So a tremendous advantage to the patient in that respect, and certainly to us as clinicians. There's still hesitation, and we kind of discussed a little bit of some of the reasons for it, and we focused primarily that most of us, in as human nature, we just don't like to have to learn a new workflow because we're very busy, and it's hard to fit this into your schedule, and if it's too complicated, whatever, it's always intimidating to open up that new box and to get things started. So we focused a lot of the program last time on the clinical workflows, and I tried to impress upon everyone the fact that there really is very little clinical change that's necessary. Now you could expand on each of these workflows and do a little bit more on the digital side, but primarily you could certainly make little or no change in your clinical technique and still have a entry point into the digital technology. The traditional wax rim bite, the impressions and bite in the dentures and immediate dentures, all of those really had the benefit of providing the design technician with a matrix in which they could use as a guide for the initial proposal of setting the teeth. Now, the directed try-in, that's where we start from scratch, where we don't have the advantage of any of these matrices information. So we incorporated the use of a device we refer to as the USB CAD and University Transfer Bowl. It's not a face bowl, but it's a device that helps us gather some information that we could transfer to the design technician to help us design, the initial placement of the teeth. That's what that crosshair idea, which gives us the tons of information and incisal length, midline, mandibular incisal length, the interpupillary plane, etc. This is kind of where our discussion ended last time, and and we're going to pick up on this part 2 and focus a lot on the prescription, which will be a little on the technical side in some aspects, but I think it's interesting information to share. The clinical try-in, very important appointment, and probably the one area that the differences will be felt on the clinical side. So it's important we discuss that to some detail. And again, the insertion to me is the bottom line. What of this technology, and that's where you'll appreciate it or be discouraged at that particular appointment. So we'll have to spend a little time talking about that. So let's start with the prescription, and we're going to focus a bit on the manufacturing process. And the manufacturing process that I'm going to be discussing, and that's what I'm most familiar with and participated in its development, is the Ivoclar Ivotion system. And this is a milling system with a variety of different discs that we could accomplish several different processing options. The two that we're going to focus on are the monolithic process and the oversized process. And I'll explain each of these separately. So starting with the monolithic process, and this is the newest kid on the block and kind of the state of the art in this milling technology for a host of reasons which we will discuss. So this is a bicolored disc. So on the surface, it looks kind of simple in a sense. You got pink and you got white, the tooth colored and the denture base colored materials. And the first impression is that these are like, glued together and then they're milled, and part of it's going to be teeth and part of it's going to be denture base, but a lot more complicated than that. And starting with the chemistry, there's a unique process of fabrication of these discs that eliminates any type of interface, chemical interface between the two materials. Obviously, there's pink and white as far as pigmentation, but the actual chemical interface there is none. And that's very important in the aspect of physical properties, because this will act as a monolithic prosthesis, truly a monolithic prosthesis. If these were bonded together, it would not. The geometry, and we refer to it as the shell geometry, and this is kind of the internal separation, geometry of separation between the two colored materials, is nothing short than fascinating. And its development is fascinating as well. So I'll try to share a little bit. There is an upper disc and a lower disc, because the shell geometry is slightly different between the two. And this particular geometry was developed by looking at a host of different dentures, that different arch forms, different tooth forms, and these were all superimposed and studied and categorized and found a common denominator between all these different tooth forms that would provide this particular geometry. Very hard to explain how this really works. I do credit the individual. I wish I was the one who invented it. I'm not, but I certainly give credit to the geniuses that really were able to put this together, because it is pure genius. And what is this? Like a sliding scale, these different troughs. Very specific, so that it could handle a variety of arch forms, a variety of tooth sizes, and etc. So that you could make a small, medium, or large denture. So it's got quite a variability built into this geometry. And again, think about the task. The task here is to make a indetectable junction between the teeth chemistry, the teeth color, and the base color, and using this geometry and different size teeth and etc. It virtually seems impossible, but it's unbelievably possible and unbelievably accurate. So looking at this ribbon of design between the upper and lower teeth here, and I'm going to talk about tooth selection in a little bit, but this particular tooth form is the Phonaris 2. So the facial part of the teeth are exactly like the Phonaris tooth forms. However, the basal part of the tooth is designed virtually differently so that it helps accommodate this ribbon technology that which also adds a degree of flexibility in providing the design technician some room for making the teeth longer, shorter, and et cetera, which I'll explain in a second. So so it does have a special iVotion tooth library, but as I said, it does pattern itself after the traditional tooth form and molds of the Phonaris 2, and it's going to be expanded to many other molds as well. So looking at it as a design technician would see it up on the screen, you're going to see that there's those rings on the top and the bottom that defines the actual disc, and then that ribbon is what defines the difference between the white and the pink material. Now we could superimpose the teeth here and see how that ribbon technology is defining the cervical anatomy of the white and the pink. The part of the tooth that penetrates is only virtual, and that's eliminated as part of the technology. But yet that length of tooth gives the flexibility that we could make some changes. So just to show you a quick example of it, we could grab an adjustment handle here, and I'm making the teeth longer, I'm making the teeth shorter, and it just shows that the flexibility into this process is incredible. Now I just did this to superimpose a disc here, just to give you a little different idea of what we're doing here, and we're basically nesting the teeth in different positions, and as a result, as I said, lengthening or shortening the teeth in this particular process, or to whatever the length that is desired. So kind of fascinating to see this on the screen. Looking at it in a profile view, the same idea. We have this ribbon technology that could be tipped and rotated so that we could shorten, in this case, shorten the posterior teeth, lengthen the anterior teeth, or vice versa. So we do have adjustment handles that we could make these particular changes. And again, to superimpose a disc here, and it kind of gives you a little better idea of what we're doing is basically tipping the disc, and that changes the nesting of the particular design between those two materials. It looks complicated. I mean, the concept is complicated. The process really is not as a design technician. Now, looking at the degree of flexibility in these different trough design, we could change the posterior teeth in unison by very easily shifting the posterior tooth segment so that it maybe corresponds better to the crest of the ridge, or for whatever you're trying to accomplish. But that degree of flexibility is possible. We could take individual teeth and move it up and down the trough, and again, that design. We could do characterization, twist the tooth, and to a pretty extensive degree. So there's really no compromise like you might think. In other words, my first thought would be, I think, that this technology is kind of limited, and you really don't have a whole lot of design flexibility. But as I'm showing you, there's actually more than in the conventional way of processing. So all this flexibility gives us the ability to do a very comparable outcome. So the junction between the tissue and the teeth is indetectable, chemically monolithic, and aesthetically there's no difference in the outcome. So very, very amazing technology. So in summary, what we're doing really with the technologies of processing that I'll be showing, these are conventional materials. And really, with this new technology, what it's really doing is taking the conventional materials and optimizing the way that they are processed. Now, we've been doing this in piecemeal throughout the process with traditional dentistry and processing, where we had the old styles of press and packing, and then the injection techniques vastly improved the processing. But now we're working with pre-processed discs, and able to achieve the optimum in accuracy. So the processing accuracy of these milled discs virtually is 100% accurate. It's virtually indetectable, any type of discrepancy in accuracy. The monolithic uniformity, as we mentioned, it's a chemical, a monolithic process, and it gives the best strength that we could get from these materials. So again, traditional materials that are optimized to their best strength. No interface, whether it's conventionally processed or milled different ways, or processed different ways with two pieces. Not having a interface is obviously a good thing. No chance of discoloration or debonding or any of the things that might occur especially if it wasn't processed properly. So the not having an interface is certainly a good thing. We discussed the different design flexibilities that gives us a very good outcome. So that was important to have. And I think most of all, especially for is one of my hesitations, excuse me, for the clinician, was that these are not tested materials, and so we're not sure of the long-term outcome and et cetera. But yes, we are. These are traditional materials, and so I think the outcome is certainly as good, and I would think a whole lot better because the way they are optimized in their method of processing. So these truly are familiar, proven materials that, again, are just optimized in their physical properties. So whatever outcome we have, I think is going to be very predictable. Are there limitations? Very few. And a lot of it is depending on the size of the arch and some of the deep faults I've noticed, and maybe a very quickly ascending ramus sometimes might give us a little challenge. And this would really mean that we have a little tip of white in these areas of the palate, or a little white in the retromolar pad. And it may be acceptable, may not be acceptable, but typically we find it's certainly well under 10% of the time where we run into these particular issues. And if we do, we chose another method of processing. The other method that we're going to discuss is referred to as the oversize process. Again, kind of a fascinating process in itself. With this technique, this is a two-piece. So the teeth are milled separately, and the base is milled separately. And both of these, with this oversized process, what it refers to is that the base and the teeth are under milled, or if you want to refer to it as oversized, so that we could bond these together, so that they're polymerized together and in their rough state. And then from here, it's put back into the mill, and you get a final mill. So this takes care of the any extra binding material or whatever, and it makes the interface virtually as small as it microscopically as it could possibly be, and as clean as it possibly could be. So this is an excellent method of processing. Having the ability to do a two-piece is very important, especially when we get into partial dentures. So we do need both of these processes, and they do have each other's back, so to speak. So how about tooth selection? And this I think is rather interesting. And I have a lot of slides here. Please, not trying to scare you with that, but we're going to kind of flick through a lot of these. But I just want you to, it's the concept that I want you to kind of see it. And I guess the potential of this particular process, because, tooth selection is and it has always been a challenge since I was a dental student, remembering sitting there with different, molds in front of me, and calling an instructor, and never having a clue on how does one actually select teeth for a patient. And the instructor would come over and kind of miraculously pick a mold out of one of these many mold charts, and and it always seemed to be work pretty good. And I always wondered, how did they do that? How did they do that? And obviously, it was a tooth mold that that particular instructor was relatively familiar with, and figured just intuitively would work for this particular patient. So it's, and then we got all these different techniques of square, tapering, ovoid, and yada yada yada, all the different things we've all been taught, and they do help to some degree, but a lot of it, truly is intuitive. And we're going to just give you a little, maybe with this technology, we could look at the tooth molds a little differently, and it really might help in your tooth selection process to some degree. Now, the molds that we have with the iVotion system are the Finaris 2, the Vivadent DCL, which is probably more familiar as Blue Line molds for those of you that use the Blue Line. And the Vivadent DCL is kind of the new mold, new mold on the block here, and very, very beautiful mold as well. So these are all incorporated into the technology, into the software, and they're put into the software as a full arch. In other words, they're preset. So they're preset. The anterior teeth, the upper and lower anteriors, are predetermined to be the right fit to one another, and the posterior teeth as well. These are all preset and pre-fit, so that they come together as a preset arch of teeth. So this is kind of a phenomenal convenience for the technician to have a initial proposal of preset teeth. Now, another tooth form, as I mentioned, is the special disc tooth library for the iVotion. And this, again, right now is based on the Finaris 2 molds. However, the length of the teeth is specifically designed to match up into the iVotion disc. So it's basically right now 4 molds, I guess you might say, that are in the design software to select from. So again, this is what we're traditionally would look at, the mold chart, and the Finaris 2 teeth are categorized interestingly. One of the kind of a breakthrough in the way these have been outlined and categorized, because primarily we will focus on the anterior teeth first, in the 3 categories of small, medium, and large. So it really was one of the first proactive tooth forms that were subdivided into these categories of small, medium, and large. Prior to that, we would kind of retrofit molds into these different size categories, but this was actually designed to be into these 3 basic categories of size to start with. And then each size was subcategorized into a soft design and a bold design. And then the different molds were subdivided into youthful, universal, and mature. So I'm showing you here the same outline characteristic that we see with the traditional paper mold guide, but we're going to look at the same molds in their preset version. And again, we're going to look at the small category first, and we'll look at the soft and the bold options that you have in this category, and again, the youthful, universal, mature. But now we're going to look at them in a blown up, very detailed oriented illustration here. This is what the design technician sees. And we see on the little icons to the left, it gives all the basic information of tooth size and arch size and et cetera that we could use just to have these numbers available. But here we're looking at, again, if we could make a study of these different molds much more than you could by glancing at molds in a mold chart. So this is just, again, using this technology, I think, to give us a little better opportunity to study, become a student of denture tooth aesthetics and tooth forms. And it's nice to have a uh, uh, a mold, tooth mold selection to choose from that is categorized into these easier to use and understand categories. So we'll look at the small, medium, and large, and we're going to go through these soft, the three different softs. And again, this was the first was the youthful, then we go to the universal, and then we go to the mature. So again, these are the three different soft molds in three different categories of design. And you can look at these and study it. You could like it or you don't, or you could choose not to like it as well. But at least you see the virtual model of these so much more descriptive than looking at on a card. Now let's take a look at the three soft bold designs. And again, youthful, universal, and mature. And we could make, again, a study of these, and we could make some decisions based on our observations. Look at the medium size, and again, we could look at their three soft designs and our three bold designs, the youthful, universal, and mature. And again, I think it's just such a graphic way to look at these molds. Not only the blown up illustration of them, but they're preset in a full arch form. And again, our large categorization of our youthful, universal, and mature on the soft side, and our youthful, universal, and mature on the bold side. So we could get to understand these molds a little bit better and see how that might, you get, because you have to start with a understanding the molds that you're gonna pick from, and then we go into the process of, well, how do I use this information that we have about this particular mold category and use it in actual tooth selection. And we're going to look at first the two matrices that we might have available, and probably the vast majority of patients that we treat today. Vast majority of people come in either with a existing denture or they're looking to have an immediate denture made. In either case, there's usually a denture or pre-extracted teeth that we could use as a matrix of information to help us guide the process, in this case, of selecting teeth. So let's take a look at what I'm referring to. Here's a case where we did a copy of a patient's denture, and we took impressions inside this copy denture and applied registration. And this was scanned. Again, the crosshair is the selection of the occlusal plane, using the teeth as a guide for this particular process. And this will give us the opportunity to select a particular tooth form, which we started with, and made a guesstimate on a tooth form that we, and you can see it kind of ghosting through the matrix. And we could, again, if this was a video or I was doing this in real time, it'd be so much more interesting. So, but it's a little choppy with the slides. But what I like to do at this particular point is I could grab the teeth, and the selected teeth, and I could reduce or bring them down to a lower level where the part of the gingival part is covered, and I could study the actual tooth mold that I had selected, and I could compare it to the matrix that I'm looking at. And depending on the evaluation that was made by the clinician in their process of evaluating the patient's copied or patient's existing denture, I could make my changes. I want it bigger, I want it smaller, I want whatever. But isn't this kind of interesting the way we could do this? So I just wanted to show how we set this up, because now let's just make a couple of examples. And let's say tooth size. So we start here, and I do this initial selection and guess, I guess. And let's say the patient is comfortable with their existing denture. By the way, I think all of us are in practice long enough to realize most times patients don't want to make big changes, even though there's negatives on their existing denture, but a lot of times they like you to stay within a familiar range of their existing denture. And so this might give us a little opportunity to study their existing setup and look at our initial proposal. And so this is a small size, this is a medium size, and this is a large. And I think we could probably, at least I made the decision that the medium kind of looks like it's in ballpark to this particular denture. Large is obviously too big. Now I could look at it in a little different graphic, and again look at the matrix of the existing teeth, and what we're looking at here is the small version, and there's the medium version, which seems to match a little bit better in arch form, and obviously the large exceeds the initial arch form. So if my goal was to select a tooth size that would stay in harmony with the patient's existing denture, I guess I would choose and feel comfortable, at least in my starting point, with a medium-sized tooth. So again, I go back to the initial tooth molds. You got to understand your molds, and then got to be able to apply it artistically and logically, I guess, to what you're trying to accomplish. So how about tooth shape? So again, let's take a look at this and do our little drop down. And we could look at this and as a soft or a bold design. And I think soft is not appropriate for this patient because those are pretty square, boxy teeth. And if I want to stay a little bit more in line with those particular shapes, I probably want to choose a bold version. Again, my particular judgment, as well it would be yours. Now, we do have morphing tools, also very important. And these morphing tools are gives us an opportunity to do a lot of interesting things, because here's our initial proposal, and these are the medium teeth. I think and these are medium bolds. I thought, we're pretty much in the ballpark, but if I wanted to tweak, I could actually do all kinds of stuff for these individual teeth and tweak them and rotate them and place them and not only just match the initial proposal, which is here, but I could kind of tweak it and by morphing and tooth positioning to make it even a little more similar and familiar to the patient's existing denture, if that is the goal that is trying to be met. But using this kind of a matrix, and you could just see the artistic juices flowing in the design technician, depending on the information that you give them in which to accomplish what you'd like accomplished. This is an immediate denture. These are pre-extracted teeth that could also be used, as I said, as a matrix. And I think this probably is the most exciting aspect of tooth selection with this digital technology, because I have tremendous empathy for the patients who are about to lose their teeth. It's a very emotional experience, and even though they may not be overtly emotional about it, but gosh, it's a big deal to a man or a woman to lose their existing teeth, and their desire is to most times sure clean up the bad looking teeth and etc. But they kind of like to look like they used to look, and so if there's even a single tooth left that is that you could gather information from, it's worth the effort. So again, you make a initial proposal, your initial guess, and we could kind of walk through morphing these teeth and make them look even a little bit closer in relationship to their existing teeth. And all these little tools are available, and they're absolutely fascinating. So that's our initial proposal, and we've made some changes just to graphically match the patient's pre-extracted teeth a little bit better. So amazing technology, and it just gives a different viewpoint when it comes to tooth mold selection, and it shows you the potential of this particular technology. So again, our initial proposal, pretty good, but gosh, we could do a little bit better. Made the centrals a little larger, a little more bulbous, and reposition the teeth to look kind of fall in line a little bit. And again, without doing this in real time, it's hard to really give you the bird's eye view of this information. But this is one way that I use to use this data and try to accomplish what I'm trying to match. And again, if there's changes that were going to be made, we can make changes as well. So fascinating technology. Now let's jump to the occlusion, because we do have an option in occlusion. And, basically there's two types of occlusion that I think you're going to be most interested in. And one is referred to as the, in this Phonaris 2 mold categories, we have the type or tip, as some people pronounce it. And that's basically a semi-anatomic tooth. And we have the Phonaris 2 lingual, which is designed for lingualized occlusion. So let's take a look at one of these at a time. And let's look at the tip or the type. And basically, this is an old lecture I used to give on the spectrum of occlusion. And there's many occlusal schemes, but the semi-anatomic is probably the most popular of the anatomic versions. And again, this is like a 20-degree tooth, if that makes more sense to you. And basically, we're going to talk about this a little bit. So if we look at a semi-anatomic occlusion, what defines it? Well, basically, in centric occlusion, we have two holding cusps. So it intercuspates similar to natural dentition. So that's why it falls into the anatomic type of occlusion, because it does kind of follow the pattern of natural occlusion. So we go into an excursion. However, we do make some changes, because in natural dentition, when we go into an excursion, the balancing side or the non-working side tends to disclude, but in dentures, we try to achieve bilateral balanced occlusion, so to help stabilize the dentures. So if we go into an excursion, we typically look like this in a semi-anatomic occlusion, which we have a multitude of contacting surfaces throughout the excursion to end up to look to somewhere in the end of the excursion to look at these particular types of contacts. So this kind of defines the anatomical occlusion. So if you look at the design of the Phonaris 2, the tip, and we can kind of look at the anatomy of the facial component of it, and it looks very much like natural dentition, because it intercuspates in like an anatomical tooth form. And if we look at it up at its side, you can see how they kind of tightly interdigitate, similar to natural teeth. Those maxillary buccal cusps are in a kind of a tight version, which is good aesthetically, maybe. For denture function, maybe not so good, because that tends to be a cheek biter when you have a little space there. So but it certainly is a good appearance. Now, if we do our equilibration, our virtual equilibration, and we look at the contacting surfaces on the upper, you can see there's a multitude of contacts on the maxillary arch and a multitude of contacts on the mandibular arch. So it's a little bit of a complex occlusion when we go into excursions and try to identify the different markings and how to adjust or what to adjust and to make changes. But this is a beautiful occlusal scheme and something that's probably fairly popular amongst most. Features of it, got the two centric holding contacts. You got the maxillary buccal cusp is engaged, as I said, but it kind of forewarned the cheek biting. Multiple contacting surfaces, which, as I said, makes it more challenging to interpret the contacts, and maybe a little challenging to equilibrate. And the intercuspation, however, the intercuspation does provide a more natural anatomic appearance. Now, how about the lingualized occlusion form? So again, our options, we'll look at the lingualized and see what defines that. So basically, the centric holding contact is one, the palatal cusp of the maxillary arch to the central fossa of the lower arch. In excursion, we tend to set or design the teeth now so that on the working side, there is no maxillary buccal cusp contacts. So we try to get freedom of contact in that area. So that can be an advantage, certainly for cheek biting, as well as the factors of equilibration. Now, traditionally, when we set these teeth, typically they tend to be a little unesthetic on the posterior region, at least looking at posterior teeth, because we have to flare the maxillary buccal cusp in order to achieve the traditional lingualized occlusion. However, we've been able to make some dramatic changes to the design of these teeth so that we could do a lingualized version that looks very comparable aesthetically to the semi-anatomic tooth form. But if you look at from the bottom up, you'll see there is a definite space between the maxillary cusp and the mandibular buccal cusp. So there is a space there, but yet aesthetically it's not compromised. So if you go through our equilibration exercise and look at our contacting surfaces, you'll see very simply in a maxillary arch that the only contacting surfaces posteriorly are the palatal cusps of the maxillary posterior teeth. So that's our goal, to achieve contact in each of those surfaces. Mandibular arch, you'll see the contacting surface in the central fossa primarily, and this gives you a little easier methodology to interpret your contacting surfaces, so that when it comes to equilibration, you can make some easy decisions. So again, in summary, the one centric holding contact, maxillary buccal cusp that is discluded, which is good for cheek biting. Adjustment is confined to the central fossa of the mandibular teeth. We don't adjust the upper palatal cusp. We try to leave those virgin. And so any adjustment is going to be on the mandibular central fossa area. So it kind of simplifies our ability to interpret and to do a final equilibration. So that's our lingualized occlusion. Communication tools, very briefly. This includes, whatever works for you, but these are denture gauges and papillometer. The denture gauge is meant to gather patient data from an existing denture, and it can be very valuable and given the design technician some information. The papillometer, especially if the patient has no dentures, it does give us an opportunity to look at the patient's lip and actually give a guesstimate on maxillary incisal length using this papillometer. So these are good tools. They're old tools. You could find tons of information regarding them, and I just felt not to spend much time in this particular program on them. And then finally, the prescription form, very briefly. Again, this is a form that I helped design, so I'll kind of show it briefly. And again, you got to select your manufacturing options. Which process would you want to be for this particular patient? And tooth selection, again, primarily focused on the maxillary anterior tooth mold, because everything else kind of falls into place, other than, of course, the tooth shade and the gingival shade and the occlusion, whether semi-anatomic or lingualized. Personally, with this particular version of lingualized occlusion for the iVotion system, I'm prejudiced towards lingualized occlusion. The communication tools, depending on the workflow that's used, just a space here to provide this information. And very important, if you didn't use nothing from this particular prescription, other than just this is nice little checkoff list to look at, to make sure that you don't miss anything as you're evaluating the patient's existing denture, or evaluating the pre-extracted teeth, or just your wax rim should have all this technical information on here as well. So that's kind of the conclusion there. So let's jump into our try-in, and we're going to spend just a few minutes on this, and we're going to look at the differences with our traditional wax try-in dentures, as opposed to what we're going to refer to now is a monolithic resin try-in. Now, this is what is going to be printed or milled, more likely probably printed. So after we do our initial design, we make our changes on the design, and then we manufacture a try-in denture. And again, this is a monolithic try-in. so everything's all one color. We could kind of dress it up a little bit by putting some, pink contrast material on the gingiva to give us a little more contrast between the tooth and base material, and that makes for our try-in. Now, each of these clinical workflows all point, except for the media dentures, all point to the direction of giving you the try-in option. So whether regardless if you do the wax rim bite, or you do impressions and bite in the denture, or you do the direct try-in, any one of these could lead to the manufacture of a try-in for the next appointment. Now, let's kind of go through the paces of our clinical try-in. And the first thing is going to be to evaluate the fit. Now, I don't know how you did the impressions. I assume sometimes the assumption is going to be on your part that these are final impressions. And the thing that you could feel reassured about is when you try in these digital bases that are digitally manufactured, they are a fairly, well, if they're milled, they are an exact replication. If they're printed, and there's different printing technologies out there, and depending on them, they're very good. But I can't speak to their if they're as close a fit as the milled version, because I don't have the experience. And so, but let's say they do. So regardless, this try-in, the fit is going to be very representative of your impression. So if it fits, and it will fit in the final version. If it doesn't fit, then you have to accept that, because it's not going to get any better, and you probably want to take a impression. So the nice thing, this is a real try-in. In other words, when you try this in, and it doesn't, as I said, if it fits or it doesn't fit, it's an absolute, there's no guess. It's just your clinical interpretation will be spot on based on the fact that these are extremely accurate, as opposed to the floppy denture bases that we've been used to trying in with our traditional technique. Looking at whatever we're evaluating, in this case, this is our try-in denture, the monolithic try-in denture. We're going to do an evaluation, and we're going to look at all the things that we look at, whether we're evaluating the existing dentures, whether we're evaluating the try-in, whether we're evaluating pre-extracted teeth for immediate denture. Same thing. We got to make a note about midline, maxillary incisal length, mandibular incisal length, lip support, the bipupillary plane. These are just traditional things we want to make notations. If we can't, you can't, but if there's an opportunity to make notations on these things, great. Lastly, in our try-in evaluation is going to be the bite, whether the bite is acceptable, and it might be, or not. And if we're going to take a new bite, we could simply just take a new bite registration, or we could, if the fit isn't good, we'd be taking impressions and a new bite registration. So it could fall into any one of these particular categories with our bite registration. So again, fit, then evaluation, and then of the appearance of the denture, tooth positioning, then lastly, the decision on the bite registration. Couple of clinical tips. Whenever we're doing an impression with these try-in dentures, monolithic try-in dentures, we're going to do a closed mouth functional impression. So let's say it didn't fit, you do a wash impression, or if you got to do border molding, whatever you have to do to make this satisfactory, but you do it with the patient in a closed mouth functional technique, makes better impressions and positions, I think, the tissue in a more functional form. Please look at your border extension. If it ain't there, it's not going to grow. And so just add some border molding material, whatever you can, to try to achieve representation of the retromolar pads on the mandibular arch and the hamular notches on the maxillary arch. Those are the two key borders that you really want to make sure that you have extension for. How do you communicate vertical dimension of occlusion? My mentor was S. Howard Payne, who I adored. And he left me with one of his sayings, and it said, vertical dimension assessment is an exercise in judgment, meaning that it is a judgmental event. It's not a pinpoint. Thank God it's not a, we don't have to be pinpoint accurate on this, but we do have to make a judgment on vertical dimension. And how do you transfer this judgment to the design technician? Well, here's a little different way of thinking about vertical dimension. Instead of just telling the technician, open the vertical 3 millimeters, whatever that means. Does it mean 3 millimeters at the incisal length? Does it mean I make the upper teeth shorter, longer, lower teeth shorter, longer? What do I do to the incisal length after I jack open the vertical dimension? So a better way to communicate to the design technician vertical dimension is maxillary and mandibular incisal length. Here's a typical example. Maxillary incisal length, fine, perfect, copy it. Mandibular incisal length, increase it. I can't see them, they disappeared. I'm guessing 3 millimeters, maybe 4 millimeters of increased incisal length. That's all a design technician needs to know. And they'll open that vertical to accommodate being able to make the mandibular incisal length to a greater, whatever it takes, vertical dimension. So vertical dimension becomes kind of a side note, but the incisal length becomes the topic. So make a deliberate effort to analyze this information for the design technician. Now, let's say we do a try-in and we want to shorten the teeth in this particular patient. You could use magic markers I did here and block that out. And that means that we're going to shorten the upper teeth, shorten the lower teeth. And in order to do that, we got to reduce the vertical dimension. It just becomes obvious. Or I ground the teeth off on the slide on the right. So where the magic marker was, I ground it off. And now that gives me what I think is an appropriate vertical for this particular patient. That's where I'm going to take my bite registration. So what does a bite registration look like? It should be you should take a bite registration at the vertical dimension that is desirable. In this particular case here, the maxillary incisal length is great, mandibular incisal length not so good. And so I opened the vertical dimension with the bite registration material, and the directions are going to be to increase the length of the mandibular incisals so they match the maxillary incisals, which would automatically occur anyway. And little tip, if you are going to take a bite registration, grind the lower posterior teeth, make room for bite registration material if you want to keep the vertical, especially at the same anterior relationship. And the nicety, as I mentioned before, is you could take home the try-in, give the patient the courtesy to, spend a little time in their favorite bathroom mirror to make some very, very important decisions. Bottom line is always the insertion appointment. This is where it all comes together or doesn't. And it's kind of the learning experience. I could say it's fair to say that myself personally and to my many practicing colleagues who are doing these procedures that the time it takes me to insert a denture is reduced at least by 75%. Sometimes I take no time. In other words, I do no adjustments, and that's my goal, is to do a zero adjustment at the day of insertion. And is it possible to do this? Yes, by many, because some of the proactive things that we talked about in the first part of the program that we could do with this technology, as far as removing artifacts and putting a selective relief and et cetera, which I'll come to in a second. Some of the articles that are written out there now, it just kind of leads to the same conclusion that digitally fabricated dentures require fewer post-operative appointments than conventionally fabricated dentures. An interesting article here on post-insertion, and it kind of categorized some of the different adjustments and that are needed post-operatively. And he said the highest frequency of mandibular adjustments were border overextensions of lingual flange and distal buccal shelf areas. And so I pay particular attention, and I don't necessarily overly engage the undercuts in the lingual flange. And I have a little pet area here at the buccal shelf area. I think our impression techniques in this area tend to lead us to overextend a bit in this masseteric notch area. And I tend to understand that. And when I'm just doing my design, I retreat a little bit in my mesenteric notch area. And I think it saves me from doing adjustments chair side. Um, and the highest frequency of maxillary adjustments, interestingly enough, were maxillary posterior palatal seals. So, and that's kind of attributed to either missing the where to put the design or over um, digging out the cast in these areas. And I kind of call it the dam, and it can cause irritations and adjustment. And it's kind of interesting how this article brought that out. And then lastly, the second highest frequency for both arches is the buccal slope of the residual ridges. And you can see with this adding this little relief proactively can certainly avoid a lot of these type of adjustments that would be done normally at the day of insertion. So in summary, how are we doing on time? Pretty good. And in summary, I beg you to consider this technology because I think it does offer the patient truly advantages that we are unable to achieve with traditional techniques. Now, obviously, each of us have different practices. I have friends who have a very specialized type practice, and gosh, I think it's digital technology probably may not fit into their way of doing things because their wax trying is an extremely intense visit, and they tend to be masters of setting teeth in wax, and they need that particular way of doing things. The wax trying might be important for especially the patient who is very detailed oriented and wants immediate changes done chair side. So again, that technology still exists and it may be applied for a particular patient. But as I get better with my ability to make changes, design changes, and to anticipate things better, I think I could broaden certainly this application to the vast majority of patients that I do treat and that you probably treat as well. But once you taste the Kool-Aid, there really is no turning back. It's absolutely fascinating technology. I cannot get enough of this information, and it's developing. It's fluid. It's getting better. The materials are getting better. The design software are getting better. The intraoral scanning devices are getting better. So a lot of things are going to be changing in the future. But remember, it's a team effort. It gives us an opportunity to get to discuss things with our patient like they maybe have in the past. But now I'm more intense on trying to get the patient's their information from the patient regarding their teeth and what they're looking for. And because I guess the reason I'm more intense about it, I can make changes now like I couldn't easily before. Your design technologist, extremely important. Obviously, we all come from different talents and etc. But you'll find the true genius lies in these dental laboratories. From what I've seen, some of these individuals are extremely artistic, and given these new tools of artistry, it's amazing what they could provide. So certainly discuss this with their laboratory and try to move in that direction as you possibly can. And certainly remember, communication is everything. And I hope I've been able to emphasize that in each of the different workflows, the matrices that I talk about, how important that is. Don't throw something at a design technician and just let them guess where to put teeth. If you could provide them some information, it's amazing how helpful that can be. So lastly, again, I surely want to thank everybody. I leave posted up there my email address if there's any questions that I haven't, or confusion that I've added to your already confused questions, whatever. Feel free to give me a shout, and I'll be happy to certainly answer the questions. Now, let me see if I could back here and see if there's any questions. Oh, here we are. Okay. All right. So one of the questions is it possible to create diastemas or alteration in the peg laterals with the morphine tool if the patient desires it? Um, there's limitation on that one aspect because the tooth forms are going to be monolithic. You can to a degree open up the let's say between the central incisors or whatever, because you could do the oversize process and do it in segments, and that could give you more flexibility. And in fact, you could do it in 28 different segments if you so desire. But if there's a need to capture that type of detail, you can do it. The laboratory could just, as I said, do the oversize process and perhaps do it in 2 segments or more if needed to emphasize the different segments of diastemas. Which system for digital intraoral impressions making do you think is best? I'm not the most knowledgeable in this particular arena, but my colleagues certainly are very successful with 3Shape in particular. The Trios system seems to be very, very popular, and again, this is a talent and a technique that you'll have to kind of work at. I do suggest to go to other seminars, webinars. A very close colleague and friend of mine, Eric Kukuchka. I'll give him a shout out. He has some nice videos online, a nice education center. You could look him up to get some more information on intraoral scanning. He's done a great amount of work in this particular arena, and I think you could hang your head on his information. Another thing, enjoyed the lecture. I appreciate that. What if a patient requests an open-faced gold or gold crown on their denture? Would this be possible? No. I don't think so. I think you're probably best to process the denture, prep the tooth, and then have a traditional gold crown or something placed onto the tooth. Interesting question. Can you custom shade prosthetic teeth after final delivery? Kind of like, can you custom paint shade on porcelain crowns before cementation? There is a technique and material and these cannular kits. They're sold, I believe, by Edmonds Dental Laboratory now, that you could do different custom shading of resin denture teeth. And it's a process. There's a bonding agent and et cetera, and different shades. You could reduce the value and things, and similar that you do on a porcelain tooth. Again, these are veneers, or at least a paint on, so it's so wearing eventually will occur on these surfaces, but it does give you that opportunity to consider that. The same for gingival characterization. There's these composite materials. We have one called Nexco. There's many out in the market that you could add some customization to the gingival tinting of the denture bases. That could give a very custom effect for sure. Okay. I think we're approaching our bewitching hour here. And if there's no other further questions, I think I will thank you for all the nice comments I see in the in the questions and answers. I sure appreciated this opportunity to share whatever information that I've been fortunate to accumulate with. Please don't hesitate to give me a shout out as questions arise. You may first encounter to, as I said, work with the laboratory and work with a design technician who could certainly that you could communicate with and be successful. So again, I thank you for attending both of these sessions, and look forward to hopefully hosting the program in the future. Take care and have a pleasant evening.